Hello everyone, welcome to another episode of Clinical Case Discussion. In this video, we are going to see mainly the complications of thyroidectomy. So, the complications of any operative surgery can be divided into two things. That is, one is intraoperative, second one is postoperative. And regarding the thyroidectomy, mainly intraoperative complications is something like universal. You can have hemorrhage. Regarding hemorrhage, one important point is that thyroid is one condition where you can have all the three types of hemorrhage. That means primary hemorrhage, secondary hemorrhage, reactionary hemorrhage, and secondary hemorrhage. What is primary hemorrhage? During the time of surgery is called primary hemorrhage. Reactionary is something within 24 hours after surgery is called reactionary hemorrhage. What is given in Bailey, and the secondary hemorrhage is something that is happening between 7 to 14 days post-op. That is called secondary hemorrhage. Okay, so thyroid is one condition where you can have all the three types of hemorrhage. And if we mainly this hemorrhage is happening one during the surgery, it will be because of the injury to the vessels. Post-operatively, it can lead to hematoma. So it is mainly because of the slippage of the ligature, especially at the poles. So slippage of ligature. The presentation will be very acute and very drastic. The clinical scenario, mainly the question, especially for the postgraduates, will be something like after around 4 to 5 hours of thyroidectomy, you got a call from the ICU sister that a patient is having sudden onset of severe breathlessness. So the main reason when you look at the wound is something like you got a tense swelling, very large one. So it is nothing but because of the tension hematoma. So immediately you have to go for remove the sutures. So the treatment will be remove the sutures immediately, skin sutures. Then you have to arrange the blood, take the patient to emergency OT, identify the bleeder. You need to ligate the vessel properly, and you need to close the wound accordingly. Okay, so this is one important complication that you can have. Second one is whenever you are raising the flaps in any surgery, there should be adequate thickness. So if you raise the thin flaps, what can happen post-operatively is that it can undergo flap necrosis. So that is another complication you can have post-operatively. So apart from the hematoma, post-operatively, one fluid collection you can have is seroma when you have little bit dead space. Please understand the complication is mainly because of the fluid accumulation, seroma. And whenever you have got seroma, it should be aspirated properly and tight compression bandage should be applied. Okay, so tight dressing. Right, next. So whenever you have got thin flaps, you will get flap necrosis. So to avoid the flap necrosis, when you are raising the flaps during the surgery, it should be of adequate thickness. Now coming to the different injuries you can have, the intraoperative complications you can remember easily with the help of the order in which you are doing the procedure. So once you make the skin incision, then you are raising the flaps, then you are cutting the investing layer of the deep cervical fascia, then you are retracting the strap muscles. After that, you are opening the pretracheal fascia. Now you are going to mainly encounter the middle thyroid vein, followed by superior and inferior thyroid pedicles. So after you deal with the middle thyroid vein, mainly when you are dealing at the poles, especially at the superior pole, you can have EBSLN, and at the lateral aspect or at the inferior aspect, you can have recurrent laryngeal nerve. So whenever you are ligating the superior pedicle, you should be very careful. You should expose the Jones triangle properly, and you ligate it. You should visualize EBSLN, external branch of superior laryngeal nerve, and you should take care not to injure it. What happens if you injure EBSLN? Please understand EBSLN is mainly responsible for pitch of the voice and timbre of the voice. So post-operatively, if you have injured EBSLN intraoperatively, pitch and timbre of the voice is lost. Okay, this is one important complication you can have. Next, this EBSLN is also called singer's nerve. It is mainly because it is giving the pitch to the voice. Okay, right. Coming to recurrent laryngeal now, it depends on whether it is unilateral injury or bilateral injury. So we will see the complications table regarding EBSLN and RLN in the subsequent slide. Now, if it is a huge goiter or accidentally you have injured trachea, if it is something like a small laceration, let's say for example something like around less than 1 centimeter or so, So you can close it primarily. So you can just adjust the freshen the edges and you can close it using non-absorbable suture material. Even if it is a large one, it will be something like a similar. But if you encounter any delayed tracheal injury post-operatively, then if it is something like a low output, you can go for conservative treatment. If it is not so, you may need to keep the patient like on NBM, and also you need to take care that you are draining the secretions properly. If it is not resolving, you may also need to go for tracheostomy very rarely. Okay, right. So you can use proline 30 commonly. This is for postgraduates. Undergrads, it's not that important regarding tracheal injury. Another complication you can encounter regarding trachea is that whenever you are removing the endotracheal tube, when you have done total thyroidectomy for a huge goiter which was there for a prolonged time. So as long as like when you remove the goiter, because of the weakening or there will be weakness in the trachea, it can collapse. So tracheal collapse is another complication you can have intraop, just immediate intraop. So for this, you need to keep the ET tube, endotracheal tube for a prolonged time. For at least 48 hours, you should wait. Then you try to remove the ET tube. If it is not being helpful, again it is there is a chance of stridor and all. You need to go for tracheostomy again. Okay, right. So next one is parathyroid glands. We will discuss this particular complication in the subsequent slide. Next, another very important complications is that if you are doing surgery after you have made the patient of hyperthyroidism normalized, let's say for example you have not properly prepared the patient for surgery, it may land up in something called thyroid storm or thyroid crisis. It is because when you are manipulating the gland intraoperatively, there will be instantaneous rise in thyroid hormone levels that will cause all the changes in the body. That is called thyroid storm or thyroid crisis. Okay. So you know that parathyroid gland injury, mainly it can be because of the accidental removal of the glands, or it is because also of the injury to the vessels which are supplying to the parathyroid glands. So it can land up in hypocalcemia or hypoparathyroidism post-operatively. And another post-op complication you can have is rarely if you have done the surgery incompletely, or there is some chance of leftover tissue, it can give rise to recurrence. Another complication before recurrence you need to remember is that if you have done total thyroidectomy, patient may land up in hypothyroidism if she is not in a complete proper follow-up, and if she is not taking the medication, so he or she will land up in hypothyroidism. Okay, so this is the list of complications of thyroidectomy. We will see detailedly what are all the required things. So first one is neurological complications. So mainly vagus is divided into recurrent laryngeal nerve and superior laryngeal nerve. Recurrent laryngeal nerve is also called inferior laryngeal nerve. So right side it hooks around the right subclavian artery, whereas left side it will hook around the ligamentum arteriosum. So you know that recurrent laryngeal nerve will supply all the intrinsic muscles of larynx except cricoid, which is supplied by EBSLN. So another one is that it is a mixer now. So sensory supply is to the larynx below the vocal cords. So whenever you have got injury of recurrent laryngeal nerve, if it is unilateral, it will result in hoarseness of voice. Whereas in bilateral recurrent laryngeal nerve injury, the vocal cords will assume cadaveric position or paramedian position. So that will cause stridor or dyspnea, and there is also a chance of aspiration also. That is why bilateral is very life threatening. Okay, so this is about recurrent laryngeal now. Let's say for example, if you have injured the nerve, it is just a transection, you can go for end to end anastomosis using very fine sutures, non observable, something like a proline 80 etc or 70. If it is something like a segmental loss, so let's say for example, if it is simple transection, you can suture it back. If it is something like a segmental loss, then you need to go for cable graft. Again, this is more important. Treatment of any complications, especially nerve injuries and all, is important for postgraduates, not that important for undergrads. Okay. Right. So coming to EBSLN, so you know that superior laryngeal nerve has got two branches again, external branch and internal laryngeal nerve. So this is inferior laryngeal nerve. Okay, right. So I told you that EBSLN is also called singer's nerve, which will maintain the pitch of the voice or timbre of the voice. So whenever there is a injury of EBSLN, it will cause loss of pitch of the voice, and also there will be huskiness of the voice when you are raising the pitch of the voice. Okay, right. So coming to internal laryngeal nerve, it is just that it is sensory and it will supply to the mucous membrane above the vocal cord level. So if at all there is any injury to internal laryngeal nerve, it will cause sudden paroxysmal nocturnal cough, and there is also a chance of aspiration. Okay, so these are the important complications regarding the nerves related to thyroidectomy. Now coming to, is there any chance of prevention of nerve injury during the surgery? Yes, especially if you are in a very sophisticated setup, there is something called IONM, intraoperative nerve monitor. So there is a device which is having electrodes. When you are inserting the endotracheal tube, you can have this surface electrodes adjacent to the vocal cords, and you can monitor the status of vocal cords entirely during the surgery. So there are two types of nerve monitoring here. One is intermittent vagal or recurrent laryngeal nerve stimulation and endotracheal electrode near the vocal cords. Second one is continuous monitoring. See, there were studies which shown little effect, which is helpful, but recently it is shown that it is not that helpful, so not so useful. But still there are corporate setups and a few sophisticated setups which are still using this particular facility. Okay, so when will you go for, especially intraoperative nerve monitoring is useful. Again, this is important mainly for postgraduates. So the main indications for intraoperative nerve monitoring is, one is whenever you are going for reoperative surgery, and also when you are doing the surgery for a malignancy or thyrotoxicosis, or whenever you are doing for retrosternal goiter. Okay, so it is helpful in reduction in risk of the bilateral recurrent laryngeal nerve injury. It was the postulate in previous days. Nowadays, the latest studies show that it is not that useful. Like there are no improvised any results when compared to without intraoperative nerve monitoring. Okay, right. Let's look at one ask a question for final MBBS people. So identify the surgery done. You can see here is the healed incision, which is nothing but a Cocker's incision, or which is also called cervical collar incision. So the surgery done is thyroidectomy. Obviously, you cannot tell which type of thyroidectomy. So if the patient is complaining perioral numbness on POD3, what do you suspect? And what are the named signs in such condition? So mainly this OSCE is dealing with one important complication, that is nothing but parathyroid gland injury. So please understand, how will you deal with parathyroid gland accidental removal intraoperatively? So please understand, you are not sure whatever you have removed, whether it is a parathyroid gland or it could be any fat. You can differentiate it. It is something like a yellowish in color, pure, or parathyroid is something like a golden brown in color. Also, you will take whatever the accidentally removed mass, and you will take a tumbler, a small vessel in a normal saline or a distilled water. You will keep that particular uh, mass or whatever the small tissue that you have removed. If this is floating on the surface of the water, it is fat. So it will float because of the surface tension. Whereas parathyroid gland will sink down because of the glandular tissue. It will sinks down to the bottom. Okay, right. So this is one differentiating feature that you can identify whether it is a parathyroid gland or fat. Let's say, for example, you have identified that it is a parathyroid tissue which has been accidentally removed. Especially when you are doing total thyroidectomy, it is very common. Like, what will you do? You will mince it into small pieces, and you can apply some radioactive substance, paint it with the radioactive substance, and you will go for something called auto transplant. Auto transplant. Where will you auto transplant this parathyroid tissue? So please understand, if you are doing the thyroidectomy for a malignant condition, so thyroidectomy is for malignant condition, then you need to go for brachioradialis of non-dominant forearm. So please understand, brachioradialis radialis of non-dominant forearm. Let's say, for example, you are doing the thyroidectomy is for a benign condition, then you can auto transplant the parathyroid into ipsilateral sternocleidomastoid muscle. Okay, so these are the two important points you should remember regarding the auto transplant of the parathyroid gland. Okay, so how will you evaluate for this hypoparathyroidism? Let's say, for example, usually here we are dealing with iatrogenic hypoparathyroidism. Normally, you have got three types of hypoparathyroidism, that is primary, secondary, tertiary. That is a different entity. Here we are dealing with the post-thyroidectomy hypoparathyroidism. So usually, the first symptom that the patient will be complaining is that perioral numbness. Usually, the symptoms will appear at around 48 to 72 hours after surgery. So, first one is perioral numbness, or there can be even tetany. She will not complain, there will be features of tetany. So, how will you evaluate for the signs then? The moment patient says perioral numbness, this is the earliest symptom. Okay. The moment patient says she is having perioral numbness, immediately you will take BP apparatus and you will check for something called, this is Trousseau's. One is Trousseau's sign. Another one is you will tap on the preauricular area and you will check for twitching, that is called Chvostek's sign. Okay. Also, you can go for ECG, where it will show the signs of hypocalcemia, that is nothing but prolonged QT interval mainly. ST segment is also lengthened. Prolonged QT interval will be there. So, if you have these positive signs, you will go for something called, additionally you will be requiring serum albumin, because you need to check for corrected serum calcium. Corrected serum calcium. You will send the blood sample to identify the levels of corrected serum calcium. The formula for this is 0.8 into 4 minus patient's albumin levels plus whatever the serum calcium levels that you have done, normal laboratory value of serum calcium. This is the value of corrected calcium. So the treatment will be, so these are the signs. How will you check for Chvostek sign is that you will just tap on the preauricular area and you can see for the facial muscles twitching. Facial muscle twitching. Whereas how will you check for Trousseau sign is that initially you will wrap the cuff around the arm and you will check the systolic BP of the patient. Then you will deflate it again, and again you will tie the cuff and you will raise the systolic BP at more than 30 mmHg of systolic BP of the patient. So let's say, for example, the patient has got initially 130 mmHg systolic. Now you will raise the BP to 160 and you will wait for around 1 minute, or depending upon max you can wait 1 or 2 minutes. Then you can observe for something called carpal spasm, which is also called obstetrician hand deformity. Obstetrician hand deformity. Okay. So it is mainly because that in hypocalcemia, why is this happening? Because in hypocalcemia, normally calcium is something is related to your neuromuscular junction. Because of the hypocalcemia, there will be hypersensitivity at the level of receptors. It is mainly because of the alteration at the level of neuromuscular junction. Okay, right. That is the mechanism. So these are the named signs in case of hypocalcemia. Now, how will you treat this means? Let's say, for example, corrected serum calcium, mainly it is somewhere 8.5 to 10.2 milligrams per deciliter. That is a normal value. So if the corrected serum calcium is around less than 8, then you can go for supplementation of calcium plus vitamin D3 tablets. One important precaution that you will ask the patient to do is drink more fluids, because there is a chance of uh, constipation. That is why you will, this is a tablet, okay, tablet form. Whereas if it is something like, this is for more than 8 milligrams per deciliter, and there are only minor symptoms. Minor symptoms. Okay. If there are major symptoms And also there is less than 8 milligrams per liter deciliter corrected serum calcium, immediately you need to go for parenteral IV calcium gluconate. So you will go for IV calcium gluconate. You will take something like at around 1 or 2 ampoules in either 5% dextrose, or you can go even in normal saline also, slowly 10 minutes, over 10 minutes, or you can go for if you are going for infusion, you can keep it at something around 1 hour. After you correct it with the IV calcium gluconate, again you will go for oral supplementation also depending upon calcium levels. Oral supplementation also. That is nothing but calcium plus vitamin D3 tablets. Okay. So this is the treatment for post thyroidectomy hypocalcemia or hypoparathyroidism. Okay. Right. Now coming to one of the most important complications during the surgery, when you are doing the thyroidectomy for a hyperthyroidism patient where the patient has not been prepared properly, how will you identify it intraoperatively? Suddenly the patient will get hyperthermia. There will be tachypnea. So ECG will also show changes of hypercalcemia, or there will be arrhythmias can also be there. So how will you treat it on table? So you need to go for oxygen for respiratory support, and also you need to go for antipyretics, and you need to support the patient hemodynamically, and you will keep the patient under intensive monitoring. The first drug you can give is esmolol IV. So 200 to 500 micrograms per kg plus infusion of around 50 to 100 micrograms per kg. Depending upon heart rate, you will adjust the dose. Okay. And because you are having mainly thyroid storm is happening because of the manipulation of the thyroid gland, which will cause instantaneous rise in thyroid hormone levels, which is happening, which is causing all the increased basal metabolic rate and other changes within the body. This is again mainly important for PGs. So one important IV anti-thyroid drug we have is injection propyl thiouracil. You know the mechanism of action is, one is it can inhibit thyroid peroxidase inhibition, and also it will inhibit T4 to T3 deiodinase. This will also be inhibited. Okay, so you can go for propylthyracil injection 200 milligrams every 4 hours. Coming to steroids, you can go for injection hydrocortisone 100 mg IV TID. Then bile acid sequestrant is useful such that this cholesterol, whatever the bile acid sequence, this cholesterol will bind with the thyroid hormone, and there will be increased excretion of thyroid hormone. So that is how this will be useful. So you can go for cholesterol tablet 4 grams per oral QID. Okay. So this is regarding the treatment of thyroid storm. Now this is one important instrument you can get in Viva the question. So it is nothing but Joel's retractor. Joel's self-retaining. It is a self-retaining retractor. Okay. Right. Coming to another question, the examiner can ask you about what are the different Cockers, eponyms. You know that you have got Theodore Cocker, who has got the Nobel Prize in regarding the thyroid and all. He is the father of thyroid surgery. So first one is Cocker's test. This test is not being done these days because it is little bit discomfort to the patient. Where whenever there is a huge goiter, you want to know whether there is stridor, whether there is weakening of the trachea. So you will ask the patient to extend the neck. You will compress the goiter with your hand, and you will ask the patient to take deep breath. If you have any stridor, it will indicate that there is tracheal compression. It's a crude test. That is why it is obsolete now. Okay. Now coming to Cocker's incision, just now we have discussed. It is nothing but your cervical collar incision. There is another Cocker's incision. It is also called right subcostal incision, which is used for open cholecystectomy. So you will go below the right costal margin. This is for open chole surgery. Another one is cervical collar incision for thyroidectomy. Next is Cocker's vein. Very rarely you can have this. In few individuals you can have this Cocker's vein. I'll show you the picture. So it will drain into internal jugular vein. So another one is Cocker's artery forceps. It is mainly useful to hold the tough structures, which has a lock here. You can observe here to hold these tough structures. It is a long artery forceps. Next, another one is cauterization of duodenum. I'll show you the picture. Mainly, second part of the duodenum, you will make a small, let's say for example, this is the second part of duodenum. You will make an incision here and you will just wind it around. Like you will turn the second part of duodenum to get access to the retroperitoneal structures at that level. Okay. So this is the Cocker's vein I was talking about. It will be present in few individuals and it will drain into internal jugular vein. Okay. Right. So this is cauterization where you are making incision at the level of second part of duodenum. This is the second part of duodenum. You are making an incision, you are just turning it around so that you can get access to the retroperitoneal structures, especially retroperitoneal. You have aorta and IVC, etc. So to get access to those particular vessels, you are turning this. This is the second part of duodenum, D2. Okay, you are turning it around to get access to the retroperitoneal vascular structures. Now, what are the important triangles related to the thyroidectomy? So one is Beard's triangle, which is also called Riddle's triangle. I'll show you the pictures. So another one is Simon's triangle. Next is Joel's triangle. We have discussed Joel's triangle in previous video. So this is Bear's triangle, which is also called Riddle's triangle. So superiorly, you have got inferior thyroid artery. Please understand, inferior thyroid artery is a very deep branch, which is going behind the common carotid artery. So inferior thyroid artery is a branch of thyrocervical trunk, which is a branch of subclavian artery. Okay. So superiorly, you have got inferior thyroid artery. This is common carotid artery, and inferomedially, you have got recurrent laryngeal nerve. This is Bear's triangle. Okay. Now, there is another triangle which is called Simon's triangle, where you have got a common carotid artery again, that is lateral. Medially, you have got tracheoesophageal groove, this one. Then superiorly, you have got again inferior thyroid artery. Instead of recurrent angina, you have got a tracheoesophageal groove. That is the only difference between Simon's and Beard's. And there is another triangle called Joel's triangle, which we have discussed during the thyroid surgery. Especially at the upper pole, it is more important to. It is related to your external branch of superior laryngeal nerve. Okay, right. Thank you.